Hello, everybody. Welcome to the RHC Billing 201 webinar. This is a part of our Lunch and Learn series for our beginning billers for rural health clinics. And this is the 201 session. It is going to be done by Amanda Dennison from Blue & Company. And here is my contact information. My name is Mark Lynn. I'm a CPA from Chattanooga. We've worked with the Rural Health Clinic program for about 30 or 35 years. Danny Gilbert is also with us. She is my partner, and she will be doing the technical stuff, except for she's not here today. She's on vacation, so that's going to be me. Good luck. Hopefully this will all work. Here is what we do: Medicare cost reports. I'm working on a couple right now. Program evaluations. We've got several RNs that will go out and help you do the program evaluation, and we'll write the report for that. Emergency preparedness, doing RHC startups. And if you're in Tennessee, we do the TennCare quarterly reports. If you've not joined the RHC Information Exchange Group, we're up to about 3,400 members or so. And that is the best way to find out about information about RHCs, about especially our webinars, or if you have questions, there's a great group of people in there that will answer questions for you. And it's a very good community to have. If you do have questions, type those in the question box there, and I will monitor those while Amanda is talking. The presentation should last about 45 minutes or so. And then we'll try to address those questions, and we'll try not to go much over 1 hour to be respectful of your time. This presentation is up to date as of today. Amanda will be talking about Medicare. If she's like me, I cannot keep up with all 50 states and all the MCOs that are within each state. That's just impossible for anybody to know that. So, but we will talk about Medicare and teach you how to do the billing there. There is the listing of the upcoming webinars. Just so you know, we're having a bunch of them this week. On Thursday, Elizabeth Burrows is going to be doing the one on grant management. So there's policies and procedures you need, all this sort of stuff. Elizabeth will be talking about that on Thursday. We're going to go to the 301 piece on Friday with Douglas Ward's of Azalea Health. So be ready for that one. It'll be a little bit more detailed, and what you put on the UBO for and all that sort of stuff will go in there. And then next week, Charles James will be doing some sort of advanced topics as well. So a bunch of sessions coming up. And then also next week, the PRF reporting and Medicare bad debts from Kraft Healthcare Consulting. We'll be doing that one. And then finally, Danny will be doing one for you Tennessee folks. Everybody else, you don't have to worry about this one, but we'll be doing the Tennessee stuff next week. So, or March the 8th is when we'll be doing that. Our speaker today is Amanda Dennison from Blue & Company. Amanda worked with the revenue cycle for healthcare. She is a member of the education committee with the National Association of Rural Health Clinics. That's where I met her, and she does a fantastic job there. She always has really great ideas, and she has really cute kids that come on there as well. So that's my favorite part of those meetings, is seeing your children. So without further ado, I'm going to turn this over to Amanda, and let me see. I'm going to make you the presenter, so you're going to have complete control. There you go. It's all you now.
All right, hold on just a second. Do you have the presentation up on your side?
I do. Let's see here.
I can open it real quick. It's just not. Okay, hold on. I can do it. Sorry. You think I'm prepared, and then I'm not as prepared as I'm supposed to be. So give me just a second. Sorry. I'll go ahead and start by talking a little bit about Blue & Company while I'm getting these pulled up. Blue & Company is the sponsor for today. They also happen to be my employer. I've been with Blue & Company for about 10.5 years now. I started out as an administrative assistant there and actually worked my way up to being where I'm at today, which is where I started working with healthcare. Blue & Company works with a vast variety of healthcare groups. Can you see my screen now, Mark?
Yes, I can. Sorry, I muted myself.
Perfect. I'll go ahead and continue with Blue really fast. But we work with a lot of different types of healthcare groups. We work with hospitals, RHCs, FQHCs, all kinds of different groups. About a third of our firm of over 450 people works just with healthcare. So I'm just a small piece. We do bad debts. We do cost reporting similar to Mark. We do anything in reimbursement and revenue cycle, 340B consulting. So if you guys have any questions about those types of things, feel free to reach out. So we are today talking about RHC Billing 201, and this is the basics of Medicare billing for RHCs. Okay, so disclaimer, like Mark already said, the billing rules we're going to talk about today are for regular Medicare only. Okay, we are going to briefly talk about Medicare Advantage billing at the end of this, but if you have questions about how your state Medicaid requires you to bill, I strongly suggest reaching out to your state Medicaid agency or to your state Office of Rural Health to get the best resources for your state, okay? Every state is similar, but every single state has nuances and differences in their requirements, so that's the best place to get your information. Let's start out by talking about what is an RHC visit. You're going to hear RHC visit and RHC encounter used
Amanda,
in the same.
are your slides moving? Because I'm not seeing the slides move at all.
They are on my side, yes.
Are on your side? For some reason, I am not seeing. There we go. I said,
Okay. There we go.
There we go. Now we're moving. Now we're moving. Thank you.
We'll get through all these technical pieces. I'm a millennial and I still have issues, clearly. So RHC visit and RHC encounter, you're going to hear these things used sort of together. Okay, so they're going to be intertwined. This definition of a visit comes directly from the benefit policy manual. Okay, a rural health clinic is a medically necessary medical or mental health visit or a qualified preventive health visit. The visit must be face-to-face and one-on-one encounter between the patient and one of the provider types that you see listed there, during which time one or more RHC services are rendered. Now, starting on January 1st of this year, that definition of an RHC encounter was expanded. Okay, so you can find this language you see here in the MLN Matters article 006398. You can plug that into Google and read the entire text. But this is what it says about mental health visits furnished using telehealth. Okay, I'm not going to talk a lot about mental health and telehealth since Charles is going to go into those next week. But I did want to point out that this does now also count as an RHC encounter, okay, for Medicare. All right, now what is not a rural health clinic encounter? Visits only for medication refills, visits only for lab results, visits only for injections, so allergy injections, B12 injections, testosterone injections, all those types of things. Suture removal or dressing change without an additional face-to-face visit, and then your nursing visits that are typically billed on a 99211. The reason these don't count as an encounter is because they don't meet one of those qualifications as we defined it a couple of slides ago, okay? Now, Medicare claim form and type of bill. All of your RHC services are going to be billed on a UBO4, okay? Or an 837I is the electronic format of that. That gets confusing for some people because while RHC services are professional services, you bill as the RHC. So you're billing as an institution, which is why we use the 837I. These are your type of bill that you're going to be using on your RHC claims, okay? 711 is your original claim. That's what you're going to be using, I'd say, the majority of the time. Bill type 710 is for a non-payment or zero claim. So if you need to submit a claim for all non-covered charges to receive a denial so that it falls to patient responsibility, 710 is what you're going to use. Adjustment claim, which is 717, is going to be something that you're likely going to use if you're adding incident to services that are taking place on a different date of service. That would be a time you would use a 717. If you just need to cancel or void a claim in general, 718 is going to be your bill type. Now, revenue codes. These revenue codes you see on this slide are specific to RHCs. 521 is going to be the revenue code you're going to probably use most often. Every single service that you provide during a single encounter has to have the appropriate revenue code attached to the appropriate HCPCS code, okay? You can do a home visit. Home visits under revenue code 522. 524 and 525 are going to be your revenue codes for your SNF or nursing facility stays, you just need to know what type of stay that patient is in. Visiting nursing services can be billed under 527. Those can be provided by either an RN or an LPN, but you do have to be in a home health shortage area in order to provide those. 528 is for a visit by an RHC provider to another non-RHC site. For example, the example they give with Medicare is the scene of an accident, okay? That does not mean a non-RHC site such as the hospital, okay? That's different. And then lastly, revenue code 900 is for any of your mental health visits. That does include your mental health telehealth visits that you now are able to provide. There are other common revenue codes that you might use in the RHC that you see listed here. Revenue code 250 is for any of your pharmacy codes. So that's any drugs that do not have a detailed J code attached. Revenue code 300 is used for venipuncture. Revenue code 636 is for your drugs that do have a detailed J code. And then revenue code 780 is for the telemedicine originating site fee only. Now, these are not the only revenue codes that you're going to use in the RHC. They're just very common ones. If you go out and Google revenue codes, okay, Medicare revenue codes, there's a whole list of ones that you can use, and you need to make sure it's attached to the appropriate CPT code or HCPCS code that you're reporting on the claim. Some RHC claim details to talk about. So you're going to go a little more in depth with this when you talk with Doug on the 25th, so at the end of this week. So I'm not going to spend a whole lot of time on these, but this is just so you understand what the basic requirements are for the claim, okay? RHCs are required to line item detail code for all the services provided during that RHC visit, okay? So any RHC services, any incident to services, any applicable professional components during that visit are all going to go on that same UB with their own line item and the appropriate revenue code like we talked about. The charges for all of these different services that you're reporting are going to roll up to what's called your qualifying visit line or your CG modifier line, okay? You'll see those used interchangeably. The only exception for that roll up is for any qualifying preventive health services. And the reason for that is because coinsurance and deductible are going to be waived for certain preventive health services. Charles is going to talk more about preventive health services next week, but there is a list out there of RHC preventive services, and it's a great cheat sheet to use for knowing when coinsurance and deductible are waived, okay? Your total charges for your entire claim are still going to report out on that 0001 line like they do today, okay? But that line is not used really to adjudicate anything, okay? It's arbitrary, if you will, but you still do want to make sure your total charges report there. Now, the qualifying visit list and the CG modifier. Every RHC claim must have a qualifying visit line identifying the primary reason for the patient encounter, okay? So that modifier CG is what is attached to identify that qualifying visit. Now, the only possible exception here is for GO 402, which is the IPPE, okay? Medicare guidance says that the CG modifier does not have to be attached to the IPPE. So if you have a claim and that's the only service provided, you may not have a CG modifier attached, okay? However, WPS does still require that on the claim. So make sure that you're aware of what your specific max requirements are, okay? The CG modifier that we put on there not only identifies that qualifying visit, but it tells Medicare which line needs to be used to calculate that coinsurance and deductible for the patient. Now, the qualifying visit list. As you'll see, the qualifying visit list has not been updated in almost 5.5 years now, okay? So what happened is when the Medicare rules for RHCs changed back in 2016 and we had to start using the CG modifier and they introduced the qualifying visit list for RHCs, originally, and if you go to that link, any of the codes you see listed in black at that link, those are the only codes that were initially allowed to serve as a face-to-face visit between the patient and an RHC provider and qualify for standalone reimbursement, okay? Now, Like Medicare does, whenever they have a proposed final rule, they have to allow for a comment period. When they opened it up for comments, they had all of these RHCs who wrote in saying, hey, the way that you define an encounter, which is what we defined on one of those first slides, we have a lot of procedure-only services that also qualify for standalone reimbursement, okay? So in August of 2016, they basically stopped adding codes, which the codes that were added are the codes you see listed in red at that link, okay? They basically said, okay, we get it, we messed up. This is not intended to be an all-inclusive list of standalone billable visits for RHCs. Now, I will say it is a very comprehensive list. It is a very good place to start from. So again, it's still okay to use it as a guide, but understand that as CPT codes are added over the years, that list is not getting updated. As CPT codes are removed, they're not getting updated. So you want to make sure that you are aware of your national and local coverage determinants to know what is allowed to be an RHC visit, and then use that logic of, is it medically necessary? Is it a face-to-face visit? Is it with a qualifying reimbursable provider for the RHC? Okay. Now, your actual RHC Medicare payment. If you've been part of any RHC billing webinar ever, you hear us say, well, you're paid your all-inclusive rate. And that's only 80% true. And that's because your actual payment from Medicare for RHC services is 80% of your all-inclusive rate. It's also less 2% sequestration when it's in effect. Okay, it's been suspended during the public health emergency, but that used to be something that would come out automatically from your claims. Okay, the only exception to that 80% all-inclusive rate payment is for those qualifying preventive health services that are paid at 100% of your all-inclusive rate, but only when they're the only service provided on that day, unless they qualify for one of the multiple all-inclusive rate payments on the same day. There are very few exceptions where that's going to happen, okay? So while the amount that you are paid by Medicare doesn't have anything to do with your charges, what is impacted by your charge amounts is the coinsurance. So I think Mark talked about when he did Billing 101, the importance of setting your charges, having a sound methodology, making sure that you're charging all people the same regardless of payer. That's why your charges are important, okay? So coinsurance and deductible in the RHC. Coinsurance is equal to 20% of the total charges submitted on the RHC claim, okay? So it's slightly different than how it is now for some of you. It is not the Medicare allowable amount, okay? So that is calculated again from that qualifying visit line identified by the CG modifier. So while you may have $50 of charges or $1,000 of charges, your payment from Medicare will be the same, but what will be different is the amount charged to the patient in coinsurance, okay? Again, those are waived for certain qualifying preventive health services. Patients must also meet their Part B deductible, and those are applied to RHC services. Coinsurance won't kick in until that deductible is met, and Medicare's payments won't kick in until that is met, okay? They will start paying your all-inclusive rate, or 80% of it, once that has been satisfied. So I jokingly titled these next couple of slides, Math is Hard, So Are EOBs, but it's very true. When you look at EOBs, there's a lot of math involved, and I think EOBs sometimes can really trip people up because they don't really know what they're looking at. So I just wanted to kind of show you a couple of EOB examples so that you can be aware of sort of what you're looking at. And there are lots of different EOB examples we could look at. This one particularly, we've got a 99214, you'll see with that CG, the amount that was billed, so that's the charge amount, is $175. This paid amount that you see is what shows as a negative ledger balance, so negative reimbursement. Again, I'm not going to go too into the weeds on negative reimbursement because Mark did talk about that during RHC 101, so you'll want to go back and watch that presentation if you have questions about that. But you'll see here, the entire charge amount fell to the deductible, okay? And that's why there is that negative reimbursement amount, because between the deductible the patient was assessed and what the actual rate is for the RHC, there's a difference. And that means that there's a negative reimbursement, okay? This one here, it's very similar, a 99213 CG modifier, $120 billed. That all fell to the deductible, but there was a difference in that and what the rate was for the RHC, okay? So that's what the difference you can see is $48.26. This amount here, $38.61, is 80% of that $48.26. This 77 cents that came out, that is sequestration, okay? And you'll see that here, it's listed. So this is back from 2020, prior to the pandemic, when sequestration was still in effect. So that is what that looks like. So when you combine those two, that's where you get this total payment amount, okay? It never fails that I have people who call me and they say, well, Medicare paid me wrong. They didn't pay me my all-inclusive rate. Well, did they pay 80% of it? No. Okay, well, they did. They paid you 80% of the remainder after that deductible was met, okay? EOBs are one of those things that the more you practice looking at them, and the more you understand them, the easier it will get. Just like riding a bike, you're not going to get it the first time, but as you start to look at them and as you start to practice with them, they'll make a lot more sense to you. But if they don't hesitate to reach out to a consultant. Reach out to somebody at Medicare. They may be able to help you, they may not, but it's always worth asking if you don't understand. So we're going to switch gears and talk about non-RHC services. So RHCs may furnish certain services that are outside of the scope of the RHC, okay? That does not mean that they are non-payable. It just means that they have a different payment mechanism, okay? So non-RHC services are billed separately to the appropriate MAC, and the way that they're billed depends on whether you are independent or provider-based, okay? So independent RHCs bill for non-RHC services to Part B using the Rural Health Clinic's CCN number or PTAN, okay? Provider-based RHCs also bill Part B, but under the parent hospital's PTAN number, okay? There's going to be a grid here in a couple of slides that is a good sort of cheat sheet for you to use for different services and how they're billed. So make sure you circle that when we get to it, and I'll make sure and point it out. All costs associated with these non-RHC services, so that's any space, equipment, supplies, facility, overhead, personnel, those should all be removed from the cost report. These are some examples straight from the benefit policy manual of some non-RHC services. The main two that we're going to look at are going to be technical components and lab services. Those are really the main two that you're probably going to hear discussed during any RHC billing presentation. Not to say that these are unimportant, they're just less common. Now again, non-RHC payment, non-RHC does not mean non-payable. It just means that payment is not based on the same payment structure as your RHC services, okay? So if you are a provider-based rural health clinic and you're provider-based to a critical access hospital, your reimbursement for those non-RHC services is going to be cost-based. If you are provider-based to a PPS hospital, or if you are an independent rural health clinic, okay, even though those two are going to bill them differently, your reimbursement is going to be based on a fee schedule, okay? Now this is the grid that I was talking about, so make sure and put a star or an asterisk or a big circle around this. So this is going to tell you if you're an independent RHC or a provider-based RHC, how you bill for these different types of services within the RHC. So this first section here is for RHC services. So regardless of whether you are independent or provider-based, you bill for RHC services the same way. You bill them to Part A on a UB04 under your RHC PTAN number. These next two sections here are your non-RHC services where things get a little bit different depending on whether you're independent or provider-based, okay? So for CLIA labs in an RHC, if you're independent, those are going to be billed to Part B on a 1500 under your RHC's PTAN numbers. Same for any technical components of non-RHC services. And we will have a few claim examples coming up that will display this a little bit better. If you're provider-based, those non-RHC services, whether it's a CLIA lab or the technical component of a non-RHC service, it's going to be billed by the parent hospital on a UB04. Depending on the type of hospital that you are provider-based to, will depend on what the type of bill is for that particular service, okay? Now, for any professional services that are done at the hospital, again, these are not RHC services. They're not even non-RHC services. These are not even performed at the RHC. They're going to be billed to Part B under your Medicare group, okay? Now, Incident to services. Incident to services are services and supplies that are integral, though incidental, to the physician's professional services, okay? So they are commonly rendered without charge and included in your RHC payment, commonly furnished in an outpatient clinic setting, furnished under the physician's direct supervision, which means the physician has to be in the RHC, okay? There are exceptions to that for certain care management services that can be done under general supervision. So just know that doesn't qualify for all Incident to services, but it will specify for that service if it's only under general supervision, okay? And then they're typically furnished by your ancillary staff, so your nursing staff, okay? All services and supplies have to result from the patient's encounter with the provider and furnished within a medically appropriate time frame. And we'll talk a little bit more about that medically appropriate time frame in just a minute. So these are some examples, again, straight from Medicare guidance of Incident to services, okay? So any drugs and biologicals not usually self-administered, and then Medicare covered preventable injectable drugs, so flu and pneumococcal, okay? Those count as Incident to services, but as we all know for RHCs, flu and pneumococcal are not ever billed on a claim. They are paid through your cost report, okay? Venipuncture. Venipuncture is another Incident to service. It is included with your RHC payment. Any bandages, gauze, oxygen, or other supplies. And then any services furnished by your ancillary staff under the supervision of a physician, okay? And again, all of this language related to these Incident to services, non-RHC services, these can all be found directly in either the benefits policy manual or the claims processing manual for RHCs. Okay. Payment for those Incident to services, like we already said, when you furnish those Incident to services, they are included in your RHC all-inclusive rate. So effectively what you're doing when you have these Incident to services, even though you don't get additional payment from Medicare, you are increasing the coinsurance amount to the patient, okay? So an encounter that only has Incident to services does not qualify as a standalone billable visit. You can include the cost of providing those services in your cost report, but on their own, they don't generate a billable visit. Now, that does not mean you can't get paid for them, okay? And that's what this last bullet here discusses. Incident to services provided on a different day as the billable visit may be included in the charges for the visit if furnished in a medically appropriate time frame, okay? So you're going to hear the 30-day rule when you hear that us talk about Incident to services and medically appropriate timeframes. There is actually not a written rule out there anywhere, and 30 days is not a hard, fast number, but it is probably the most commonly practiced and the easiest to keep up with because people will look at it on a month-by-month basis. Okay, so that's why you hear it called the 30-day rule. As long as it is furnished in a medically appropriate time frame, you can still go back and attach it to an otherwise billable visit. And again, there will be some claim examples coming up that will look at this. Okay, so when we look at these claim examples, they are going to be basic elementary claim examples so that we can get our point across of the revenue codes, making sure you have the CG modifier, the roll up, things of that nature. You'll probably go into further depth on claim examples with Doug at the end of this week. So make sure you tune in for that. Okay, so this is a basic E&M office visit only. Okay, you've got your revenue code 521, your 99213 for the service provided, the CG modifier attached, and your total charge. Pretty straightforward. You're going to get reimbursed 80% of your all-inclusive rate, and the patient is going to be charged 20% of this $100 of coinsurance. Pretty easy, okay? Same if you have a procedure only. It does not just have to be an office visit to qualify for standalone payment. It can be just a minor in-office procedure. Same thing, 521 revenue code. You're going to have a procedure code instead of an E&M office visit, still have the CG modifier attached, still have your charge for the service. Again, this claim here and this claim here result in the same payment from Medicare, but the coinsurance is different because of the total charge line here, okay? Now we start to introduce our non-RHC services, okay? So this is an E&M office visit and an EKG. This is when, because we've got the professional component, we're gonna have the professional component on one claim, the technical component on another, okay? So this here is the 99213, you still have your 521 revenue code, and the CG modifier identifying the primary reason for that visit. You have the $100 charge for the office visit and the $50 charge for the professional component of that EKG rolling up here, which is what gives you that 150, okay? The professional component of your RHC services, so long as they are completed by your RHC provider, can be put on your RHC claim. Again, what you're effectively doing is increasing the coinsurance amount, not increasing your reimbursement from Medicare, okay? Now, the technical component of that is going to be billed differently depending on whether you're independent or provider-based. So again, going back to that graph that we had before. So for independent RHCs, the tracing only element or the technical component of that EKG, so the 93005, is billed to Part B on a 1500 claim form. You're going to receive fee schedule payment for that. If you're a provider-based RHC, the parent hospital is going to be billing the 93005. And if you're you're provider-based to a PPS hospital, you're going to get, again, fee schedule payment. If you're a critical access hospital, you're going to get that payment based on cost, okay? So again, professional component on your RHC claim, technical component, which is a non-RHC service, will go on a separate claim. Okay, so now we're looking at Incident 2 services, and you really have two options when it comes to these Incident 2 services. So that's why I wanted to look at both. This claim looks much the same as what we've looked at already, right? We have our 521 revenue code, office visit, CG modifier. Here we have different revenue codes, okay, because this is a J code drug, so it goes under that 636 revenue code. It has its associated charges here, all rolling up to the top line, right? Nothing different about that. What is different is if you choose to report your additional line items with a penny charge, okay? You can do that. It is an option that CMS gives. Again, your amount here is still rolling up to your 215 and capturing your 2 pennies here, but your total charge line here at the very bottom, that 0001 line, doesn't look as overstated if you're going to report using a penny. Now, whether or not you report your additional line items with a penny charge is going to be up to the functionality of your billing system. So whoever your software vendor is, you need to have the conversation with them to say, what is your recommendation? What do other RHC clients that you have do in this scenario, so that you are coming up with the best answer for your clinic, okay? What fits one clinic might not fit your clinic because you have different systems. Now, this is just strictly opinion, so take it for what it's worth. This penny method can get very messy. I understand that a lot of people like it because it doesn't make your AR look as overly inflated. And again, if you have a system that works beautifully using the penny system, more power to you. But just beware, it can get a little bit messy sometimes, okay? So do what's best for you based on the functionality of your system. Okay, this is when you have an incident to service that takes place on a different date than the face-to-face office visit, okay? So what I want to point out here, again, we had the initial office visit with the 521-99213 CG modifier, still the charge of $100. When the patient came for this, the provider said, I want you to come back once a week for the next 4 weeks and get an allergy shot, okay? So we're attaching, and these are arbitrary amounts, so if you don't charge this amount, don't feel like you should. These are just for example only. The charge for that allergy injection, we said, is $10. So if they came back 4 times, then that's $40. So again, even though it takes place on a different date of service, as long as it takes place within a medically appropriate time frame, we can submit a bill type 717 to add these allergy injections to this office visit. The date of service that you're going to use is going to be the date of the office visit, okay? Don't use span dates on your claim. That will not come out well in the end, okay? So again, options for your incident to services, and then what you should do if it's done on a different date, okay? Now, you can also choose to hold your claim until all 4 of those allergy injections have been done before you submit the claim in general. Again, if you have a good workflow in place for doing that, that's great. Otherwise, submitting an adjusted claim under that bill type 717 to add those on is acceptable as well. Okay, Medicare Advantage plans. We're going to touch on this just briefly, and here's why. There are 3,834 Medicare Advantage plans available nationwide as of 2022. That's the most that there have ever been. That means that there are 3,834 different sets of rules, okay? There is no one size fits all when it comes to Medicare Advantage plans, okay? Your Medicare Advantage plans are going to pay you according to how you are contracted with that individual plan, okay? Again, similar to your state Medicaid, there may be similarities, but they are not going to all be the same, okay? They're not automatically going to pay you as an RHC. You need to go back and make sure that there's contractual language added to your Medicare Advantage plans to say that they are going to pay you as an RHC and that they'll process claims like regular Medicare, okay? Reach out to them early in the process as you're going through, or if you haven't done that yet, reach out to them now so that you are aware of any billing requirements that they have and any paperwork they may need you to fill out. It may be as simple as filling out a provider maintenance form. They may have other forms that they need you to fill out, okay? But again, a lot of them do follow similar billing rules as Medicare, especially if you're contracted with them as an RHC, with some exceptions. They may have you bill the flu and pneumococcal differently since those are typically reimbursed through the cost report, okay? So be aware of that. Here are a few helpful resources that are in here. Again, the benefit policy manual, the claims processing manual. There's a lot of good information at the CMS Rural Health Clinic Center about various topics related to RHCs, and it is updated pretty regularly. And then last, the claims processing manual, chapter 25, that's going to give you more information about completing that UB. So we are back to questions.
Okay, thank you, Amanda. That was awesome.
Sure.
Yeah. So
I know I went really fast, and that's a lot of information. So if you have questions, please feel free to ask.
That was a lot of information. And we do have a listing of questions here, so I will just go straight into these. I did, for you guys to know, Charles James, Helen Williams, and Janet Linton. I made you guys panelists, so you have access to your speaker there. If you just click on the little red button, you can talk if you would like to chime in to anything we say. So the first question is, why do they not use the 20% of the Medicare allowable for co-insurance as they do for non-RHC services?
Your guess is
I don't know why.
Mine.
I thought this is great. Maybe you'll know the why.
Because Medicare can't do anything the easy way. That's my answer. I don't know.
I'm going to write that answer down. That's good because Medicare can do anything easy. Yeah, Medicare is never consistent. That's one thing that
No.
drives you crazy. There's not a lot of consistency. Okay, good. I'm glad I wasn't the only one that didn't know the why of that. So the next one is the EOBs are so confusing. Is there any webinars of the past that can explain negative amounts better? I did a little bit of it on the one the other day. We will, in the 401 session there that I'm going to do with Charles next week, I will add that and we'll put some negative reimbursement examples in there and do some of my old accounting T accounts there and sort of walk you through it. So
it's very tricky.
Yeah, it is. Okay. Let's see here. Okay, questions. Okay, here we go. Question about technical component services. Our provider can do the EKG, X-rays, and read them at the same time. So he bills both the the TC26. How would this go to the RHC?
So if you are doing the entire EKG, if you were not in an RHC, you would bill that combined 93000. In an RHC, you're required to split them out, even if it's all being done in the RHC. Okay, the professional component goes on your RHC claim with your other RHC service that are provided that day. The technical component has to get split out separately, and if you're provider-based or independent is going to depend on how you bill that. Again, Medicare is not always logical. It's just the billing rules that exist for RHCs. So even though you're doing all of it at the RHC, you've got to split it out between professional and technical.
Yeah. I always tell people there's no globals in rural health clinics because everything's driven by face-to-face encounters. So that's why there's no globals. Will we be emailed the slides? Yes, most of you were sent the slides ahead of time. If you signed up late, then you'll get it after this. We'll have, once the recording is done, I'm going to send out everybody that signed up. And do remember, we had about 10 of you guys that gave us the wrong email address. Some of you, I could tell it was bad typing, but double check those emails, because if you want to get the stuff from us, you're not going to get it if you give us a bad email address. So let me see here. Okay, this is a good question. Is there a list of what is considered incident to services?
Medicare only gives kind of a small list, really. There's not necessarily CPT code by CPT code listing of all incident to services. Again, if it's something that's generally furnished by your clinical staff, it's an incident to service. If it's something that's done by your provider, okay, and it's medically necessary for your provider to do so, that's going to be an RHC service.
Yeah. One thing that always bugs me about those incident to the rules there, when you read chapter 13, section 120, it talks about what an incident to service is. I think it's 120. And it says that a physician must be it says direct supervision, which means a physician has to be in the building. That's always uncomforting to me in that rural health clinics don't have physicians in the building most of the time. We have nurse practitioners and PAs. So I think it does say, but it says underneath there, it says, if it's your policy that a nurse practitioner or PA can be in the building and count for an incident too, then it's okay. So
yeah, the Medicare benefits policy manual actually has different sections about incident to a physician service, incident to an NP or PA service. So it does kind of go into a lot of that. But again, there's not any listing the way that we have a qualifying visit list. We don't have an incident to list. So.
Yeah. And I just wish they would put physician, nurse practitioner, PA in that little section 120, because that would make
provider would be fine. Yeah.
Provider would be great. So let's see here. This is a good question too, because I always get confused on these 25 modifiers. Will we not add a 25 modifier to the visit for the injection administration and the shot, or just the 99214 CG?
So I don't know if Charles is going into this at all about multiple visits on the same day during 401, but generally speaking, there are only very specific instances when you're going to use a modifier 25 or 59 in the RHC. And that's going to be what we call subsequent illness or injury. So what that means is the patient came in the morning, they had an office visit to be seen for a follow-up of a cold that they were having. They went home, they were making themselves some hot tea to feel better, dumped some hot water on their hand and burned their hand, had to come back. They had a separate diagnosis and treatment, even though it was on the same day. And so therefore, depending on what service was provided at that subsequent visit, well, you could put a 25 or 59 on it then. You should. But again, that's about the only example where you're ever going to use a 25 or 59 in the RHC.
It's very, very rare. So yeah, absolutely. So don't use 25s, and in the situation like Amanda said, you probably want to put a 59 on there. So okay, this is a good question in that we're going back to our EKG question here. It says you're talking about the MPI or the TIM on bill it for on a separate professional using a different MPI number for that. And Jennifer is from Tennessee, I know that. So that maybe, I know we've had that issue with June 28th of last year, Palmetto put up a little notice saying that they had these new edits that CMS had put out, and if you build stuff non-RHC, then your claims are going to get rejected. We had a ton of people getting their claims rejected because of that. So is that happening in other MACs that you know of, or is that just Palmetto?
I haven't had any of them. I work mainly in Kentucky, Indiana, and Ohio, so CGS and WPS, and I haven't had any clients who have told me. That doesn't mean it's not happening. It just means they haven't specifically told me that it's happening. But if that maybe sounds like a Tennessee only issue, it could just be an issue with your MAC processing it incorrectly. Generally speaking, your professional services that go on that RHC claim, you're billing as the RHC, so it's under the RHC's NPI number. But the technical component, again, that could just be an issue that Tennessee has. Gosh, Tennessee,
I think it's
get it together.
Yeah, it's a Palmetto issue. So if you have Palmetto as a MAC, that's why you're having an issue here. So, okay, this one looks hard. Let me see. Amanda mentioned on the slide with the independent versus provider-based graph that hospital professional services are not rural health clinic. Isn't swing bed professional hospital visit considered rural health? So swing bed is always confusing because swing bed, you can swing, it's a bed, and Amanda, you correct me if I'm wrong, but it's a bed in the hospital, and I know this because my mother, she was in a swing bed at one time. So she first broke her back, she was in the swing bed. When Dr. Davis came by and saw her, he billed it as a hospital visit. Glenn is a rural health clinic, one of our clients. So the hospital swung her over to a nursing home bed, that same exact bed. She didn't move, but now all of a sudden it was a nursing home bed. So when he came there, that could be an RHC visit, and you would bill it that way.
So if it's at the hospital, then that is not an RHC visit. If they are in the nursing home, then it can be billed as an RHC visit. There are certain things in terms of making sure that a record for that nursing home patient exists as part of the RHC, not just that you can log into the nursing home, department, if you will, but they have to have a record that exists for that patient at the RHC. So maybe that helps identify that difference in the swing bed issue.
Yeah, okay, that's good. I hope that answered Diane's question. Can you go over what services are not covered under an RHC visit?
Anything that has a frequency limitation to it. I don't know if you mean just what Medicare doesn't pay for, but if it's something that has a frequency limitation, it's over that frequency limitation, Medicare is not going to pay for it. If it's something that is not medically necessary, so it's cosmetic in nature, those are things that are non-covered for an RHC, or for Medicare in general. So anything that's never covered by Medicare is not going to be covered under the RHC either. Again, those non-RHC services, that example, there is a slide in here that gives you a listing of non-RHC services, and that's different than non-covered. If you go to the benefit policy manual, there are different sections for non-RHC versus non-covered, and it does give you examples in both of those sections. So I would use that as a guide to know what doesn't qualify as an RHC visit and what qualifies under those two other categories.
Yeah. I always described it as there's this umbrella. There's a big, huge Medicare umbrella, and under that umbrella, there's RHC services that are over here, and then there's non-RHC services that are still under the umbrella, and then you're out in the rain when you have non-Medicare services, things like cosmetic services. If I went to get something cosmetic to make me look halfway presentable, then and then maybe that would be non-covered under Medicare. That would be the type of service that we would be looking at. So when I get my Botox every week, that's not going to be covered. So Okay, which is a scary thought. Okay, if your charge, Steve has a good question here. If your charge is less than your all-inclusive rate, would your all-inclusive rate be reduced to your charge?
No. So even if you only charge $50 and your all-inclusive rate is $100, you're still going to get paid 80% of your all-inclusive rate. SQHCs do have a lesser of language, and that might be what you're mixing up with it. But RHCs do not have that lesser of language in terms of if your charges are less than what your rate is.
Yeah, that's Steve comes from a hospital background, and hospitals were very familiar with when I was doing hospital cost reports. Lesser cost of charges, that was always drilled into you. RHC is one of the, there's always exceptions to the Medicare rules, and RHCs is one that has that exception. Okay, and then Wendy has a comment here about the additional co-insurance is bad for the patients, and yes, if you have to, it actually does cost on average. And I would complain to Medicare about this when my mom would go to the RHC and see Glenn. It's like, well, you know, when she goes there, she has to pay $40 in copays. While if she went to Dr. Bill across the street, it would have been $18 in copays. But
yep. Yeah, so that is an area of patient education to be aware of when you become an RHC, because again, when they get their EOBs, when they're looking at them, their coinsurance is going to likely be slightly higher. So again, you'll have to explain to them, no, we haven't raised our rates. It's how we have to charge coinsurance based on the type of facility that we now
are. Yeah. And I don't know if we have time to talk about this. Is a little bit more advanced. This is an annual wellness exam, sort of, or not annual wellness. A woman's there's really no such thing as a woman's
a exam.
Yeah, well, woman, but it's sort of a part of that for technical labs like PAP collections. How do you bill for these?
So I know that's something that Charles is going to go over in his 401 presentation. So he's talking on March 1st. I'm pretty sure, Charles, correct me if I'm wrong, but he probably has a slide example in there that goes over exactly how you should bill a well woman exam in an RHC.
Yeah.
Not trying to avoid the answer, but I know that he's going to talk about that.
It's going to be a lot, and that is a hard one to answer. I didn't actually expect you to answer, but I thought, well,
it's okay.
Yeah. Let's see. Do MA plans have to follow the same 365-day filing rules? So,
you know, I actually don't think I know the answer to that.
I don't either. I mean, again, I always think of MA plans as being just sort of like commercial plans. I would think they would have. I mean, the usual Medicare rule is you have what 300. You have 1 year from the date of the service, or the date of the visit, to file them timely. Otherwise, you're not gonna get paid for it. So okay. Let me see here. Let's see here. I'm struggling. Going through here. Okay, here we go. Transition. Oh, here's an easy one. Okay, transition care management service. Would this be counted as a visit for the cost report? I'll take that one. Yes, you would. You do count that on the cost report. That was easy.
There you go.
I noticed that you had a 0636 revenue code on injection administration and allergy injection. So I don't know. I think she may be questioning whether 0636 is the proper revenue code, because I get those confused too, whether you do a 250 or you do a 521 or.
So 250 is for anything that's just like a pharmacy code that doesn't have a J code. 636 is for if it does have a J code. I may have put the wrong one on the 96372. Somebody can correct me if I'm wrong. If I did, we can fix it and send it back out.
Yeah, yeah, I'm not sure. I always get confused on those as well. Tell you what, we have, oh my goodness, we have about 700 billion questions. I will work on some of those. Oh my goodness, you guys are really asking a lot. So I am gonna not take any more of Amanda's time, because we could answer questions all day, but I think we'll cut it short. I will keep up with your questions, and on the last session that we do with Charles, the 401 session, we will answer the most common questions that you have.
I'll plan to participate.
Can you discontinue being an RHC was one question. Is yes, you can. It's very easy to get out. I got somebody out today, so it's very easy. Amanda, thank you for everything. I appreciate it. Charles, Helen, Janet, I know we opened up your line. If y'all want to open it up, if you want to open your line up and say something, you can. Otherwise, we're going to get it. Charles, I knew Charles would open his line. Hey, Charles.
I just want to say, what a great job. Hello. Great job, Amanda.
Thank
Well
you.
done. See everybody next week.
Okay. Thank you, Charles. Thank you, Amanda. See everybody. Thank you for coming. Bye.